Welcome to the GMO Academic program. Today's lecture is on bleeding during early pregnancy. We have invited Dr. PROBHODANA RANAWEERA, who is the Honorary Consultant Obstetrician and Gynaecologist attached to DIPLOMA Maternity Hospital for Women and National Hospital of Sri Lanka. Dr. RANAWEERA graduated from the Faculty of Medicine, University of Colombo in 2005 with a second-class upper division at the final MBBS exam with distinctions in 6 subjects. His exemplary performance during the final MBBS exam was awarded with 6 gold medals, which included the gold medal for the best performance in final MBBS. After his local training in obstetrics and gynecology, he spent 2 years in the United Kingdom at Whipps Cross University Hospital, where he completed his postgraduate training. During this time, he became a member of the Royal College of Obstetrics and Gynecology. Dr. PROBHODANA RANAWEERA joined the Faculty of Medicine, University of Colombo in 2016 as a lecturer in obstetrics and gynecology, and he has many publications in index peer-reviewed journals and has authored many book chapters on obstetrics and gynecology. And being a compassionate doctor, he introduced a special program to provide support to bereaving mothers, which was launched in June 2019 as Rosebud Service at the professorial unit of the DIPLOMA Maternity Hospital. So let me warmly welcome Dr. PROBHODANA RANAWEERA for today's lecture. Let's listen to Dr. PROBHODANA, and if you have any questions related to bleeding during early pregnancy, please send them over through the chat box. We can discuss them at the end of the lecture.
So good morning, and thank you, Charuni, and the GMOA for inviting me for this event. And I'll be discussing about bleeding during early pregnancy now, which is very important and very common, because most of you, if you are especially doing general practice in Sri Lanka, many of you have a very unique relationship with patients. So much so, sometimes patients believe you more than sometimes the things that we say, right? So that relationship should be maintained, and it's a very unique relationship. And because some of you guys may have seen this patient when the patients are when they are children, and they have been family physicians for many years. Similarly, if consultants are listening, you will come across patients with bleeding, whatever the profession you are in. So there are a few principles that we need to kind of discuss. So I'll be discussing about so we'll be discussing about the clinical evaluation of patient presented with early pregnancy in a what we call non-obstetric setting, and to kind of appreciate there is a spectrum of miscarriages. When you call there are certain complications like miscarriages, and we have to kind of identify new entities like pregnancy of unknown location, pregnancy of uncertain viability, and about molar pregnancies, which have been listening from our faculty days. Right now, one of the presentation would be somebody who's pregnant and before 12 weeks coming with vaginal bleeding. And so to kind of discuss anything, we need to know what are the possible causes. So the causes can be either pregnancy related, which is the commonest thing to happen. So you have to always remember that they can have pregnancy related bleeding, whether it's a miscarriage, an ectopic pregnancy, or that's molar pregnancies, or anything to do with the pregnancy. And also there are a lot of non-obstetric reasons, like there can be vaginal bleeding, and sometimes even somebody's maybe having hemorrhoids, and sometimes they can't differentiate between whether it's a hemorrhoid bleeding or a vaginal bleeding. So in that case, also you have to be careful, and you have to take a proper history. So because anybody who's pregnant and if seeing blood, either when they are passing when you're using the toilet or even, wiping themselves, it's a kind of a alarming symptoms, because we always tell that if there's bleeding or anything to seek medical advice immediately. So they might come to you all or to any obstetrician or gynaecologist. So depending on whoever is available, they usually try and seek your help or even give you a call and see there's bleeding, what to do. So it is important that this is appreciated, that they are concerned and they are worried, and it's up to us to kind of give the proper advice. Now, one of the take-home message from all this lecture today is to remember that all women in reproductive age group are having an ectopic pregnancy until proven otherwise. That is something you have to remember, because if you remember that, and if you always suspect that, before you retire, I can assure you, you would have saved at least one patient's life. That is something, whether you are working in a pediatric ward, in a patient who have never had a period before, right? And we have had instances where patients are telling that I have never touched the hand of a man, right? Probably they are telling the truth, they probably wouldn't have touched the hand, right? So that may be also the problem, but we have come across this, whether there had been nuns, teachers, meaning answers, we have come across wide area of patients, and we always have to suspect, because that can kill that woman if we don't suspect that. So it's very important that you appreciate that. The problem with the current, the modern age is that we can detect a pregnancy at a very early stage, right? So much so, if you do a urine test, the day after you missed your period, or the patient misses the period, she can theoretically detect a pregnancy by a good HCG strip. So most of the patient will do their test usually after about a week, so they detect the pregnancy around 5 weeks. Now again, this is a problem, because we think that 5 weeks comes after, from the first day of the last period, and we assume that she ovulated on day 14 and she conceived on that day, and then we calculate 5 weeks. But we have to remember there are recorded pregnancies at each day of the pregnancy. Like for instance, if somebody has got pregnant the day before they are having period, they will not have the period. They will always think that they had a period on the whatever the month before. But so they can have even though they are saying 5 weeks, they can be just 1 week. And so that have to be remembered. That's why the dates are always wrong, or most of the time wrong, from the LMP. And so if somebody is coming with abdominal pain or PV bleeding or anything to do with the pelvis region, whether in a pediatric ward, surgical ward, medical ward, you always have to remember whether there is a possibility of ectopic pregnancy, and it takes just doing a urine strip test, which is very cheap and can detect, because it detects when the beta HCG level is more than 20 in the blood. And for us to see it from the scan, the beta HCG levels should be more than 1500 at least with a good scan. So you can detect the pregnancy way earlier when you do a urine. So if it is negative, you can be 99.9% sure that this person is not pregnant. So that is very, very important to distinguish between pregnancy or not pregnancy. That's number one. And obviously, if somebody is coming with a collapse stage or acute abdominal things, you have to go with your ABC approach. As anyway, I always tell that, because sometimes when the patient is collapsed, some people get panic and try to send the patient to the hospital or somewhere, and they can die on the way. So evaluation and initial resuscitation is very, very important, and then only think of what's happening, right? So we'll start one by one. When there is early pregnancy bleeding, the commonest cause would be what we call a miscarriage. Now miscarriage is a spectrum of diseases, right? So it can be from threatened miscarriage, which is, now if somebody is coming with a PV bleeding, and then if they have gone, now their usual history, if you're taking history, they will say there are a little bit of spotting, no significant pain, she has not passed any clots or tissues, right? And the bleeding has stopped now. And then if you do a speculum which we hardly do now because of the ultrasound scans. If you do a speculum, especially in a, let's say, GP setting or in a hospital where there is no scanning facilities available, we look at the cervix. And if the cervix has, if the cervix is usually closed, sometimes you may find evidence of bleeding, like which is in the posterior fornix of the vagina, where there may altered blood, little bit of bleeding, or there's no evidence of bleeding at all. And if you do the scan, and then we will see a pregnancy with a heartbeat, or an embryo with a heartbeat. Now, if you see that, so we call it a threatened miscarriage because there is a threat to miscarry, but the pregnancy is okay with a heartbeat. The good news is you can reassure that patient, because you can say 95% of the time this pregnancy will proceed without any issues. So you don't need to be alarmed. If the heartbeat is there, we can do. And in the hospital setup or in the private sector, we tend to give progestogens in these instances because that's the only thing we can give, right? Like injections or vaginal pessaries or even oral progestogens. However, if you really look at it, the evidence is not there for it, but still most of us, including myself, we give because that's the only thing we can give. And this is with the assumption, because you all know that in the first 12 weeks, the pregnancy is maintained by corpus luteum, which is the organ formed in the ovary after ovulation, until the placenta take over the secretion of progestogen. So until the first 12 weeks, especially in the first 1 month or 4 weeks to 6 weeks, the corpus luteum is the main supply of progestogen. So if the what we call corpus luteum is dysfunctional, that may help, that may cause miscarriages, and that's the assumption that we do when somebody is coming with a threatened miscarriage, that we give progestogen to kind of supplementary, thinking that the corpus luteum may be dysfunctional, but in real life, majority of the time, it is not. So there's no indication for progestogen, but as I told you, most of us will give progestogen. That's what we call threatened miscarriage. And then there's another patient, especially they might end up with your GP, or usually because it's painful and lot of bleeding, they will usually go to a hospital or the casualty unit. So they will complain of severe pain, bleeding, and they may have past issues. And if you do a speculum, you will see that the cervix is open, and sometimes usually there's something there in the cervix, right? So we have to remember that any woman, when there is dilation of the cervix, it causes pain. That is why some women complain of period pains, because when there's clots or anything passing, the neck of the womb opens and it's equivalent to labor pain, right? Whether it's 1 centimeter, 2 centimeter, 10 centimeter, the pain, the initial instances would be the same. So usually, if that's it, if you do a scan, sometimes even the heartbeat is there, but it has come out basically. If it is in the cervix, if it is in the external os, means that it has the majority of the pregnancy is inside the cervical canal. So it is what we call an inevitable miscarriage. It's going to come out soon. So usually in that instance, we can take the pregnancy out. We usually use a sponge forceps, and then the sponge forceps, we can hold the pregnancy and pull it out. The pain goes away immediately. So usually the patient thank you first, then only realize that she has lost her baby and start crying. So you have to remember that it's called the inevitable miscarriage. So there's no way, there's nothing else we can do until we manage the miscarriage and then do the counseling. So there is something called silent miscarriage. I'll come to that. That is like, now usually what happens is a patient comes to us, we do a scan and we say like either heartbeat is there or not there. Sometimes if the heartbeat there, we ask them to come at 12 weeks, usually for the dating scan. So when they come at 12 weeks, when we do the scan, there's no heartbeat. And because earlier there was a heartbeat, now there's no heartbeat. Patient usually say that they didn't have any bleeding, no, nothing basically. And also sometimes if you really inquire, they might say, okay, her pregnancy symptoms improved. Say I had nausea and vomiting earlier, but after last couple of weeks, it was not there. She start feeling hungry again a lot, right? But not the, like normal pregnancy symptoms are not there anymore. So the earlier days we used to call it miscarriage, right? But then being obstetrician, we don't like that word, because as if we have missed the miscarriage, right? So that is why it's called miscarriage. So we use the word silent miscarriage. But when we use the silent miscarriage, patients start not liking it, because it's like, nothing happened. We are kind of blaming the patient, right? Earlier the patient was blaming us. Now we are blaming the patient. So now the newer term is what we call intrauterine fetal demise. But because I didn't put it, because we still use miscarriage or MMC, silent miscarriage, or even IUFD synonymously. So anything is meaning the same, that we have lost the pregnancy. So that is what we call silent miscarriage. And sometimes patients come with bleeding, and then when we do the scan, when we look at the neck of the womb, it's still open, still bleeding is there. Patient says she has past tissues, but when we do the scan, either the sac is there, or the thickness of the endometrial cavity is about is more than 1.5 centimeters, depending on the cutoff that you take, or 2 centimeters. And if it is more than that, we call it incomplete miscarriage. Of course, if it is less than 1.5 or there's nothing inside the womb, we call it a complete miscarriage. We have seen a pregnancy early and now coming with a complete miscarriage. So these are the spectrum of miscarriages that we see. And so the important things of knowing that, right? Though it's because if it is a threatened miscarriage, especially, patient comes and usually they're bleeding, so they go to the, let's say, casualty, and they say everything is okay, give a progesterone shot and then send them home. And usually they will come to the sometimes the general practitioner and say, we had this, what is happening now? And you have to you can reassure, you don't need to worry, 95% of the time you're going to carry this baby home, right? Which is a good thing. And all the other things, then we are going to discuss about the counseling in the next slide. But important thing is knowing this will give you, because if it is complete miscarriage, again you have to say, don't worry. And one important thing is that when it's a complete miscarriage, now earlier days we used to say patient to wait for 6 months, 12 months before you start on another pregnancy. Theoretically, if the patient gets a period, in her first period after the miscarriage, she's physically ready for a pregnancy. But it takes a little bit of more time for the psychological preparation. So we usually say 2 periods is enough if somebody has done proper counseling. We'll come there now. Right. Now, the miscarriage, for instance, in 2017, in Sri Lanka, 400,000, about 450 something, so let's say 500,000 women got pregnant, and out of that, 100,000 had a miscarriage. So if you take 100 years, it's 10 million or 100 lakhs. So you can imagine, so any event or normal life events are associated with the miscarriage. For instance, if somebody go on a journey, that's the cause of a. We usually say, duragaman yandepa. Long distance traveling causes miscarriages. So it started with going on a horseback, started miscarriage, they stopped it. Then you go on a tirikkale, then you start bleeding, it stopped that. Then you started the push bike, then you stop that. Then motorbike, the car. Now new thing is, when you are even going the car, the bumpy roads, Raje Baro, right? So all that will cause miscarriages, right? Climbing stairs, eating certain food. For instance, every country has, let's say UK will have, they have their certain food. For instance, apple, they don't eat apple, we eat apple here. We don't eat papaya, papol mehikanne, but in England they will be eating it. So because these are common things that we use day to day, so 1 in 5 women miscarry. So there is always, if somebody gets pregnant, there's a 20% chance of miscarriage, and it's similar around the world, 20 to 25% around the world. And other countries have evaluated why they're having miscarriage, and they have found that 99% is due to fetal anomalies, usually chromosomal anomalies. We know that from chromosome 1 to 46, any of those are one more or one less is not compatible with life, apart from Down syndrome, which is trisomy 21. Trisomy 18 and 13 also can, pass through this filtration, but we can detect them at 12 to 14 weeks. But usually they also don't survive the pregnancy, or soon after birth they will die. But Down syndrome, out of all these trisomies, only Down syndrome and Turner, which is the less X or more X, what we call crime factor, those are the patients who can, live to adulthood than one. So the important thing is that when the patient comes, because a lot of doctors don't do it, because for us it's a normal thing. Every day I see 2 to 3 patients with miscarriages. And being doctors, it's a very common thing. So we say, something like that. Okay? But studies have shown whether you lose the pregnancy now or after 12 weeks, intrauterine death, child, infant death, or let's say neonatal death, infant death, or let's say losing a 20-year-old, 30-year-old, the feeling the patient or the family gets is the same. The emotions are the same. And not only for the woman, the husband and the whole family is the same, right? So the only difference is the time that they take to come out of it. Right? So for a person who have lost a 20-year-old, 30-year-old, those parents may never come out of it. But usually if you do proper counseling, the patient who have lost a pregnancy in the first 12 weeks, usually after about a couple of months, they will come out of it. But again, you have to remember, for the patient, the losing the pregnancy become a distant, unpleasant memory only after taking a baby home again if they have planned a baby and lost the baby. So that's again something you have to remember, right? So one important, when you are counseling a patient, to say that it is nothing to do with what you did or didn't do as a couple, right? Because everybody goes through what we call the grieving process, right? They will, if somebody says that you have lost something, now usually what happens to is like, one VOG says, okay, now there's no heartbeat, so earlier that same person would have said everything is okay. So they come, another scan, no heartbeat, sorry, this is a miscarriage. They don't want to believe that. They will go home and they will go to another VOG. We call it denial. It happens all the time. And then the other person will say, show here, no heartbeat, so sorry, we can't do anything. So then they go to this other phase of what you call grieving, which is we call the guilt and anger. Now, usually when it's less than 12 weeks or that it's usually guilt. The patient and, family feels certain things. Usually after, like IUDs, there's all that is anger towards the doctors, the caretakers for somebody, right? But the important thing, majority of Sri Lankans, parents go through this, they don't come out of that guilt. Imagine somebody let's say UK with proper counseling, when they come, you say, here, you have lost the baby. We are very sorry about it. And it's nothing to do with what you did or didn't do. We know that very likely this is a chromosomal thing. We don't even need to check the pregnancy because the studies have shown before the heartbeat, 99% of the time it's a fetal anomaly, which is not compatible with life. And they will hug each other, cry, and they know that they go home. So compared to a Sri Lankan woman, the mother-in-law said, that's something, or the mother think, okay, if I didn't go on this trip, my baby is still alive. If I have money, if I can go in a car instead of in the bus or in the train, I still have my baby. So that's something you can't forgive yourself, and you will feel it again and again, and that can affect future pregnancies. It's important to tell, and especially the husband and the family, right, with the mother-in-laws and in-laws and everybody, you have to say that this is nothing to do with her. Even if we keep her on a bed, not allowing her to get down from the bed, and even the toileting is done on the bed and given only the food that is supposed to be given in pregnancy, this would have happened because the fate of that pregnancy was decided on the day of conception. And so nothing to do with that. So you have to give that message again and again, because to kind of make them go to the next phase, which is what we call becoming truly sad. They will then become truly sad. Yes, we lost our first baby. And that's the word they will use. So in our counseling, we usually try to say pregnancy, embryo, color layer, pregnancy, color layer, those are the ones. Because we don't like to use the word baby because we emphasize what they have. But still, for them, they have lost their first baby, second baby, third baby, whatever. And you have to remember whether it's the 10th baby after 9 normal babies, or the fourth baby after 3 miscarriages or the first pregnancy loss, their feeling are the same. Okay, so you can say, no, you have to appreciate that it's the feeling are the same. So that is very, very important to be what we call empathy. Right? So we have to feel what the patient is feeling. It's very important, right? And so I spend a little bit of more time on that. So the number one is that, because this is where most of the time you have to play a role, right? As GPs, what you call MOH doctors, or you have relations and anybody, because you are the doctor in the family, right? So and you will see many people with miscarriages, or you will encounter miscarriage. They will say, we learn what happened. They always want to ask that same question again from you also the moment they see a medical professional, right? So it's important to emphasize it's nothing to do with that. And that's number one. Number two is to kind of, because sometimes it can be really, really emotional. So for a month, for them to feel sad, crying, and we can say the home atmosphere is like after a funeral, right? No music, they don't have sex sometimes. They'll be sad. That's okay. And please don't tell anybody don't be sad, right? Then they are not human. If they are galtics, then you have to send them for counseling or psychiatric referral, because there's something wrong. If they don't feel it, they are human. Everybody is human. They will feel sad. They have to cry, they have to do that. But if it is lasting more than a month, that can be abnormal grieving, and you may have to refer them to special, like either a psychiatrist or a psychologist. That's also important, right? And please don't tell them, don't have babies for 2 months, or 6 months, 1 year. They can try after even 1 month if they want to, but usually we say for 2 months. Okay, so this is because most of us will get in. And also if somebody says, okay, they are pregnant, don't ask them not to tell even their parents. Wait till everything is okay. Usually after the heartbeat, 95% of the time this patient can carry this. Then only you start telling this, and the gummy clinic thing and all has to be happen. Because usually what happens is the moment they're pregnant, they go, because they get involved in the pregnancies, but sadly 20% of the pregnancies are lost. So they feel it more, right? Right. So this is important, how the counseling should happen, right? Now we'll come to another thing which again a lot of people come to you, that is because people can know the pregnancy at a very early stage, we have a now new entity called pregnancy of unknown location, right? So we don't know whether it's inside the womb or outside the womb, whether it's an ectopic, because the problem is anybody coming to you or us saying that their urine HCG is positive, whether at 4 weeks or 4 plus 1 day or 9 weeks, 10 weeks, we have to find the pregnancy, because now they have had a what they call a contact with a medical professional. Our first assumption is still this woman is having an ectopic pregnancy. So we have to exclude an ectopic pregnancy before we move on. So in that instance, we use serum beta HCG levels, because we want to know whether we can see it from this. So we do a scan, we can't see the pregnancy, right? Even from the transvaginal scan, we need to see a beta HCG level of more than 1500. That is with the very good scanners. The most of our scanners are like, we are seeing Anjalangeli. We have to imagine things, right? So in that case, it's usually about 2500, 3000 only we can see the pregnancy, right? Now what we do is, we do beta HCGs 2 times, 48 hours apart from the same lab, because each lab has a different value, okay? So you ask them to say, lay blood today and kind of look at it. If it is less than 1000, you know that you can't see this pregnancy. Then ask them to do it in another 48 hours with the same lab, and then you look at the values. If there's a more than 60% rise, let's say 100 has become 200, then you know very likely this is an intrauterine pregnancy. So you say, okay, come back in about 2 weeks' time. If there is a drop of more than 50%, 100 has become 50 or 200 has become 100, then wherever the pregnancy, whether it's an ectopic pregnancy or an intrauterine pregnancy, it's very likely it's a miscarriage. We can't do anything. We call them biochemical pregnancies. 100% anomalies, usually chromosomals. In between is the problem, where the rise is not 60%, and even though there is a drop, it is not 50%. then you have to suspect an ectopic pregnancy. I have had full-blown, you know, with the 2 liters of what you call hemoperitoneum with 100 beta HCG levels. So you have to, don't take it lightly, you have to still kind of look at it, but you have to remember if it is there, then you have to wait. But still, not like other countries, we'll wait and see, because in our system, patient can come to the hospital quickly, and they usually come. So you have to kind of wait, because now, let's say, in the UK guideline, it says the beta HCG levels are more than 2,500, and then you can't see the pregnancy, you have to go for a diagnosis laparoscopy. And then you do a laparoscopy, we call it a negative laparoscopy. So you can't see the pregnancy inside or outside, or it's not outside. And after about a couple of weeks, then you see the pregnancy inside. But sometimes it miscarries, because if you give general anesthesia to a pregnant woman, there is a 1% chance of a miscarriage or a, you know, fetal demise. So because of that, we wait, but we have a very close watch. And of course, if it is more than 3,000, 4,000, that is in our setup, we will think of doing an ectopic pregnancy. But if you are seeing, I mean, as non-specialist, you always refer this patient to a specialist to deal with. Right? For your is, make sure if somebody comes and tell you pregnant, do a beta HCG. And people, I don't know why, sometimes people just do a serum beta HCG, whether it's positive or not. We don't need that. We need the level. If you're taking blood, we need to do the level. If you're doing the urine test, it becomes as positive or negative. So after that, if you are suspecting or they are complaining of abdominal pain, ask them to do a beta HCG level and go and meet a doctor. That's the best thing to do. Right, and the next one is what we call pregnancy of uncertain viability, again because of early booking, right? And in a way, we have to be proud that more than 90% of Sri Lankan women will book before 8 weeks with the MOH, best in the world, right? So all the other countries, they book later, right? But by doing so, the problem is that then they come early, because she can theoretically be 6 weeks or 5 weeks also if the pregnancy occurred later than a normal ovulation that we calculate, right? So then we see a intrauterine pregnancy. We know that it's not an ectopic pregnancy, but there's no heartbeat. Sometimes even not a fetal pole also, right? So the embryo we can't see, nor the heartbeat. Now, earlier days, especially when we were training and when we were medical students, there were cut-off, right? So we measure the fetal pole, or we measure the gestational sac. If it is above the certain cut-off, we say it's a miscarriage, and the following day she's admitted for ERPC. Because we didn't have medicine also those days, it's always ERPC. So then later in 2014, they found that some of these pregnancies would develop a heartbeat later, in about 2 to 3 weeks time, 1 to 2, 3 weeks later they will say. So then they changed the guidelines. So obviously as a trainee, I would have terminated the pregnancy without even knowing. Some people who had let's say sub-fertility for 10 years coming with IUP, and we measure the gestation sac, it is more than 25, we say, okay, here, this is a miscarriage, admit following day for ERPs. And if we waited, sometimes they may have developed a pregnancy. We don't know, right? So then in 2014, the guidelines say we wait for 2 weeks. We see a pregnancy inside the womb, then we know that ectopic, so we don't need to worry. We wait for 2 weeks and come after 2 weeks. If the heartbeat is there, it's a normal pregnancy. If the heartbeat is not there, we know it's a miscarriage for sure, 100%. So that is the 2014 guideline. Now there was a problem. Now here, usually what we say is, we say, okay, no problem, come in 2 weeks time. But in another country, you can't say that. You can have to say, okay, there is the pregnancy inside, but we don't know whether this is a good pregnancy or whether this is going to be miscarriage. So then they go home thinking, and uncertainty is the one which kills a lot of people. We don't know, like for instance, if we take a biopsy of let's say a tumor, we want to know whether it's a cancer or not. That is why we do it emergently. But waiting, let's say you have to wait for 2 weeks to know whether it's cancer or not, that kills a lot of people. It's very difficult to wait. We want to know whether it's a miscarriage or a good pregnancy. We want to know whether it's cancer or not cancer as quickly as possible, right? So the new guideline, which is in 2018, which say if you do a transvaginal scan, which we can see 10 times magnified, we do it once, and after a week we can do it again. If we see the heartbeat, it's okay. If we don't see the heartbeat after 1 week, 2 transvaginal scans, then we say it's a miscarriage. So by waiting, it's because to reduce the anxiety. So that is the new guideline. But still, most of us will wait for 2 weeks, to be honest. So the way that we counsel is slightly different. We say, okay, pregnancy is inside, so they go happily. And the moment now in my practice, the moment they come after 2 weeks, when they are going to, because I'm not lying, I'm saying, okay, pregnancy is inside. I need 2 weeks to say whether it's good or bad. So just go home and come back in 2 weeks. You have come very early. So in 2 weeks, when they come, when they're about to get onto the bed, I say here, today I have to see a heartbeat. If I see the heartbeat, everything is okay. If I don't see the heartbeat, it's a miscarriage. So the anxiety is only few seconds, and then you do the scan, heartbeat is there or not there. Okay, right. And the last today is about the molar pregnancies. Right now, these are not common; they're rare, but we always have to suspect that. And again, they comes in a spectrum of disease, from partial mole to complete mole to something called persistent trophoblastic disease, choriocarcinoma and other malignancies. Right? So all this can present as molar pregnancies. The important thing is now, because of the medical what we call management of miscarriages. Now early days we do a ERPC, so we always send these tissues for histopathological analysis. But now we hardly find it, because when with the medicine, usually when they have an abdominal pain, they go to the toilet, and usually the miscarriage happens in the toilet. So we can't take the specimen out, right? And sometimes we can miss molar pregnancies unless there are specific ultrasound features. Now there is something called, especially the persistent trophoblastic, there is no overt features of what we call molar pregnancy, but the trophoblastic tissues are there. So any woman whose beta-HCG levels after the miscarriage are persisting after 56 days is considered as persistent trophoblastic, molar and all that. So it always, once if somebody has a miscarriage, the first advice is after 2 weeks, after the, we say whether it's a ERPC, whether it's a medical management, after the procedure is over, after 2 weeks they have to do a urine HCG test at home. If it is negative, then we say that pregnancy is over. If it is positive, she needs to do a serum beta-HCG level, and she has to keep on doing it every week until 56 days. And she has 56 days for it to become negative. If it is not becoming negative after 50 days, then they have to be managed in a different way, which is a rare thing to happen. So these are the important things. And then another entity I which always talk about is about terminations. Now you know that termination is illegal in Sri Lanka, right? Unless to save the mother's life. However, right, the latest data, which is in 2019, says that there are 1,000 termination happens per day in Sri Lanka, more than the birth rate. And this is the time where there is no what we call misoprostol, or what you call the normal medicine available. But this is the time where the spoke combis and enteronet is venting, right? Where we are supposed to report these patients if they come with termination. But now, because of the medical management of either miscarriage or termination, both, we can't even we don't know the number of miscarriages happen. So that's important. Terminations happen. Now the important thing is, sometimes as the GPs, you will get to know the truth. And sometimes as VOGs, we also get to know the truth. Sometimes you will be, you will be told about here we had to do a termination, or they will come and ask you for help. So remember, your values, your religion, your whatever the things will have no effect. And so please don't put your values to your patients, right? Whatever it is, you have to. If they come with a miscarriage, you have to termination. You have to manage her, and you can't be judgmental. You can't scold her, because according to Prof. Arul Kumaran, I don't know whether you heard of him. It's Prof. Arul Kumaran, Sabranathan Arul Kumaran, or we call him Professor Sir Sabranathan Arul Kumaran. Now he is from Sri Lanka, and he's where, if you see somebody who can go to the pinnacle, he's our kind of our role model, because he has gone to the highest place from Sri Lanka in obs and gynae. So he's the professor or now retired professor or emeritus professor, but he was professor in St. George's in London, and he became the president of the Royal College of Obstetrician. He was knighted for his work, and he became the president of the International Federation of the Obstetrician Gynecology. That is our biggest organization. So he has done, like all that, and he has, like, recently, I don't know whether you know that Ireland legalized abortions, because Ireland was like Sri Lanka. They can do only termination to save mother's life. This is part of England, but still, because it's of the Catholic upbringing, they were. So he kind of promoted this campaign, or he joined hands with the other women and all the organization to legalize abortion in the UK or in Ireland. And according to him, there are only two types of people in this world: people who encourage illegal abortions, or people who encourage legal abortions, right? Because once a woman set her mind to do a termination, nobody can stop her, right? Whether it's legal, illegal, she will get it done. And again, sadly, in Sri Lanka, if you have money, you can get abortion, and you can even go to India and Singapore and get it done. So it's always the patients who can't afford, who are less fortunate, who are suffering, will suffer more. So you have to remember that part also. So it's very important that we know this thing. And now because I'm trying to kind of say something like the College of Obstetricians for the last many years, we have put a parliamentary thing to terminate lethal anomalies. And the second one is to terminate rape patients. I have delivered a 13-year-old raped by her father, and she didn't even look at that baby, and you can imagine that son. And I have lost a mother giving birth to an anencephaly baby, where we know that 100% that baby is not going to survive, and she was a mother of 2, right? And I've lost 2 mothers who had illegal termination when I was a registrar, who came with septic shock. And the moment they admitted, one patient, we did a laparotomy, and she had the whole abdomen was full of pus, and we removed everything. She died 1 day later, and when I came from the ICU, other 2 children were wriggling their legs on a parapet wall near the ICU. So these are the memories that we see. So the important thing is to remember. Now don't get me wrong, I don't do abortion, so don't send me patients. That's number one, right? So that is because of the legality, because I don't have anything against it, but because of the legal framework, we can't do it. But at the moment, with a lot of difficulty, we send it to the parliament to get it, and then the parliament was approved, but before it was passed, they send it to what we call the religious leaders committee. It's still there for the last 2.5 years. Okay, because none of the religions will help these patients. Nobody is going to raise a Down syndrome baby. Nobody is going to have that. None of them. Sad. So this is something we have to remember as doctors when these things comes, to raise a voice, because we have to be the champion for voiceless, and because women can't. And sadly, it's for the people who can't do anything. Anybody who can do anything, either the worst case, they can go even to Singapore and India and get it done if they have money. So remember that. Right. So this is my talk today, and thank you for listening. And the take-home messages are: number one, all women are in the reproductive age group, which is now considered at 11 years to 53 years. If they come with anything, you have to suspect an ectopic pregnancy, or we go by the premise all women are pregnant and having an ectopic pregnancy until proven. Otherwise, that's number one. Number two is that, when it comes to after a miscarriage, ectopic pregnancy, any pregnancy losses, regardless whether ectopic or anything, please remember the counseling part of it, and to make sure that they are not felt guilty at the end of the day, because sometimes even the doctors say, yanda tibbanikmenta hospital or something like that. No. Right? Parisangvela no, there is nothing called. So if this Parisangvima is there, then there is no what we call the animal kingdom. Right? So we were also for the last 10,000 years delivered babies and without any doctors, any nurses, any midwives. Okay, so remember that. Third one is that if you see somebody after a termination of pregnancy or thing, you have to be professional. You cannot judge that person. It's whatever their decision. You have to manage the medical part of it only. That is my take-home messages. And once again, I thank Charuni and the members of the president of the GMOA for inviting me. And a good day to all of you. Thank you.
Thank you very much, Dr. PROBHODANA RANAWEERA, for joining us today. It's your busy schedule, and it was very interesting and very informative lecture. And thank you all for joining us today, and see you in 2 weeks' time.